Hi, George. Good to see you.
Hey Herb, how you doing? Once again, it's a Tuesday morning, elevating great physicians.
Great. We have with us today Dr. Drew Hertz, and he's going to talk to us about large pediatric slash OB networks inside a big health system. And how do we use quality dashboards to measure and improve care? Welcome, Drew.
Good morning. Thank you for having me.
Good morning.
So for those of you that don't know you, you have led 200 physicians, was that correct? Some pediatricians, some OB, and
Correct.
some employed by the health system and some in private practice?
Correct. Before I retired from the health system job a year ago or so, I was in charge of 200 pediatric and women's health providers. So it was both physicians and midwives and nurse practitioners. And they were all in the community. So doing general OBGYN and general pediatrics. None of them were independent physicians that I oversaw, although we did have those also in our accountable care organization, which I helped run. But these were all employed physicians or nurse practitioners within the health system.
Well, how do you get buy-in from that many cats?
It's hard. It was a lot of fun. I thoroughly enjoyed it. It's challenging because you're really balancing you're on a tightrope with three different weights. And you have to balance what's best for patients, what's best for the doctors, and what's best for the health system. And that's your daily balancing act. And if you truly are a good advocate for the physicians, then you begin to get buy-in from them. And yes, it takes time. It takes a lot of building of trust, building relationships. Fortunately, I grew up in this health system. And so a lot of the physicians I had professional relationships with, eventually they became that I had helped train many of them at the hospital or trained with them at the hospital. But it takes a long time to build that trust. Herding cats, yes, sometimes it is herding cats.
And so the more you advocate for the physician, depending on the health system's leadership, you start annoying the health system.
It's a balance. It is a balancing act. You have to, I can't say it enough, do what's right for the patients, do what's right for the doctors, and do what's right for the health system. And what's right for all three of those audiences is not aligned, as you know. They're very different. So it is a balancing act, which is why it's such an interesting job. And I always felt people said, don't you miss your patients in your practice? Well, first of all, I always practiced. I just stopped seeing patients 6 months ago, and I'm eager to get back to it in some capacity. And that's another way you build trust, is by being in the trenches somewhat. But you always have to remember that you're now helping improve care for thousands of patients, not just your own patients, when you take on an administrative role. You have to have that mindset that you're really trying. Every time you help a doctor, you're helping their patients.
Yeah. And so you must have had tons of dashboards, and it doesn't really matter whether you use Power BI or Tableau, but it's just a way of visualizing data on a daily basis.
Correct. And the different doctors used it different amounts, but we were on a several-year journey to develop dashboards that were actionable. And the first step is you have to make sure the data is trustworthy. And that alone takes time, because you'll show doctors data, and doctors, they'll just tear it apart and say that doesn't apply to me. So it's got to be accurate. There's going to be errors in every dashboard, but what you're hoping for is that it's consistent errors. So it's a methodology error, not an error whether it's accurate or not. And hopefully you understood what I meant there. They're extremely helpful. Once you get the doctors to trust the data, hopefully it's actionable too, so it's not static. They can drill into it and see how it can help them care for their patients and improve their quality scores. It was a great journey, and you're right, it's just a visualization tool, but how you use that visualization tool, it's hard to say that, how you utilize the visualization tool is very important. It's very important. We can get into that if you want. But
Yeah,
I think
but I think, most of us don't really like EMRs too much because they weren't built around our needs. And so I think, and when you first talk to a doctor about data collection and why it's important for their finances and why it's important for quality, they will always tell you, I'm a really good doctor. I run a tight ship.
Yeah.
I don't need to measure. That's a waste of time. And they don't even know what they're not doing right because they have that mindset. So how do you go about presenting data so that a physician can understand it and start buying in and improving their own care?
well, the first thing you have to start with is you can't improve what you can't measure, or you can't improve what you don't measure. And although there's all sorts of theories out there about change management, I, over the years, kind of developed my own for physician change management, which I think is very different. And if you go about these steps that we've learned over the years, buy-in is much better. And so the first step is you have to appeal to their altruism. Doctors want to do what's right and what's best for their patient. So hopefully you have some national guidelines, national recommendations of why you want to measure something. And sometimes it's just because the insurance companies tell you to. It's the worst possible reason, but that's sometimes. But hopefully the Academy of Pediatrics or somebody's behind you that's giving you reason of why this is important. What is the impact on your patient? So you educate them and you tell them this is best practice. And they may say, well, I do developmental screening. Well, if you don't use a standardized checklist, are you really catching everything? And surely doctors will say, I do it. Well, if we can't measure it, you can't do it. And then the doctors will say, well, it's just checking a box. Checking a box, but hopefully if they're checking a box, they're actually doing something as well. So anyhow, you appeal to their altruism to do what's right. The second is you appeal to their intellect by educating them about why it's an important measure. You appeal to their ego, which may be the most important one, in that I think you have to have transparent data. You start with just giving them their own data and proving them that it's right, but eventually it's got to be public. It's got to be public, so you're appealing to their ego. And hopefully then the next is you appeal to their wallet, right? They have to have some financial gain. Hopefully not all health systems have financial gain. It's just a penalty or just an embarrassment. But hopefully, they can make some more money for checking the boxes, which is basically what they're doing. You also have to make, next is simplify their life. So if you are asking them to do something that is not part of their regular workflow, you're going to fail. It's got to be part of their regular workflow. And even better, can it be part of their staff's workflow? So the staff's documenting what they're doing or what they're supposed to be doing. Then you get a win, which is another one is give them resources. So give them tools, give them things that are specific for their workflow to help their patients. If you want antimicrobial stewardship, give them the reasons behind it. Make sure the EMR has the right antibiotics in it and the right dosing. Make it simple. If you want their vaccination rates, make the workflow simple. Maybe have it so the staff, if the MA is giving the shot, they click something that then gets recorded as given, or use their CPT billing guide. Don't make them click something if you can prevent it. And engage the whole staff. Often when we would educate, I told you we take the national standards, we would teach the whole staff, why is something important? Why is fluoride varnish important? What's the long-term impact for kids? Teach the staff. If you're doing depression screening, whether it's adolescent or maternal depression screening, teach the staff why they're giving this form out. What's the importance of it? Why are they checking a box? So get everybody engaged. And again, if you can, don't put the doctors in charge of the documentation of it. Put the staff, because they'll do it. So it's a long answer, but it's a long journey. But eventually, if you make these dashboards helpful, you educate them as to why they need to do something, make it financially rewarding, you can drive change. Oh, and let me recap, appeal to their ego.
Now,
so first we start, go ahead.
These metrics that you use, they have to be standardized by somebody? What are you using? You're saying national standards.
So we did a mixture of HEDIS
Hmm.
measures because that's what the Medicaid plans wanted.
Correct.
And we even did our own. So, for example, we felt safe sleep was very important. It's one of the few things pediatricians can do to reduce infant mortality is safe sleep. So we had the doctors or somebody, in our case it was the doctors, have to check a box that they did the ABCs of safe sleep at certain visits. So yes, it was extra step. They had to check a box, but hopefully if they were doing it, if they were checking the box, they were talking about it. We did literacy promotion. We felt it was important. There's no HEDIS measure on literacy promotion that I'm aware of, but we all felt that can make a difference in the trajectory of kids' well-being long-term. Teach them reading. So are you talking about reading at 2 months? Are you giving them a book or whatever each practice wanted to do? But you had to do literacy promotion. And then we did the standard ones that we had to do: vaccinations, well visits, depression screening, antimicrobial stewardship, things like that. But I think I was most proud of those, which were not the national ones, that we just decided what we wanted to do. We were measuring fluoride varnish, maternal depression screening, safe sleep, and the other one I just said, literacy.
Now, the safe sleep and the literacy, okay. Medically, I guess it's a good thing to do. It's the right thing to do. But why would they do that? Other than it's the right thing to do. There's no money attached to it.
It's the right thing to do. And then when you know that your score is going to be publicly available, you know, some cared, some didn't. There were always doctors who said, you know, I'm not doing this, and they didn't get their few $100 bonus, and they didn't care whether their score was 5% and everybody else's was 80%.
Yeah, but there was no money attached to those two metrics.
Yeah.
So when we get money from Medicaid or insurance plan, we would decide what the metrics are in order to get that money.
Got it.
We would make that own decision. Now, we had to hit certain targets to get the money,
Right.
but how we distribute it, we would decide. And we had, you know, a group of governance, pediatricians who are governance, and we would vote and decide.
And so how did you decide that? Because there's always a tug of war there. I have, I have the most patients, but mediocre quality. And somebody has very few patients, and then it's really easy to have high quality. If you're just starting out and you're seeing 5 patients a day, I can click all the boxes you give me to click.
Yeah.
But I can't have a bigger share of the person that's seeing 30 kids a day and is doing, a good job, not a great job. So how did you parse that out?
Excellent point. We weighted it based on your patients you saw. So most of these dollars, so there were some commercial dollars involved, but most of it's Medicaid dollars. So it was weighted by how many Medicaid patients you saw during the measurement period.
Right.
And that was done for several reasons. One is just what you pointed out, Herb, that it's much easier if you only see 10 patients a day than if you're seeing 30 patients a day to hit those quality metrics. So it was based on weighted how many patients you saw. The other reason is Medicaid patients in general are more complicated and take longer, and it takes more resources to take care of them. And you get paid less, right? You get paid less to see more complicated patients. And so we weighted it based on your Medicaid visits, although we reported on all the patients you saw.
Okay. And so when you say your Medicaid visits, are we talking about your well child visits or all Medicaid visits?
I think it was, when we set it up, it was all Medicaid visits.
Oh, so
not,
the sick
not
visits.
just your well visits. And that's also because your well visit rate for Medicaid patients is much lower than for commercial patients, but they're coming in more for sick appointments. And that takes time and takes effort. So it was both. Remembering also that, like vaccinations, usually people only do it at well visits. But if they aren't coming in for well visits, you still want to get their vaccinations in. So this encouraged people to get vaccinations during sick visits as well.
Correct.
Yeah. And how did you measure the antibiotic use? Because that's always a tricky one.
Extremely tricky. And then all of this, there's ways to game it, right? So we would pick otitis media, let's use that for an example, or pneumonia. You had to have the right diagnosis, and then the right antibiotic had to go with it.
Okay.
But if you wanted to play the game, you would just pick the right or a different diagnosis, or, you know, like URI,
Right.
you couldn't have an antibiotic with it,
Correct.
right? If you did that, you get dinged for the proper treatment of URI. So you just have to call it sinusitis if you want to play the game, but hopefully you're diagnosing correctly. So there's always ways doctors can game it. They can also check boxes without doing something, but you appeal to their altruism, as I said, to do the right thing, to do what's right. So antibiotics was a little tricky, but you had to have, if you had certain diagnoses, strep throat, you had to have something. If you had pharyngitis, there better not have been an antibiotic prescribed for pharyngitis. It had to be strep throat. And then you could make sure it was the right antibiotic. And it gets tricky because then you have to worry about allergies, but we would never set our metrics at 100% or even 90%. You look at where people are and how they're achieving, and then you try to increase it each year. But it's never 100. When people would say, well, what about the parent who refused maternal depression screening? Well, that's fine. But are your patients refusing it more than Dr. XYZ? They may be. And that was hard with vaccines. So there certainly are pockets. We had 200 doctors. It's a wide geography. And there certainly are pockets of people who refuse vaccines at different rates. So, and you definitely saw that geography difference.
Yeah. And so I'm just, again, curious. So you weighed the Medicaid visits and then the quality, and that informed the whole bonus they got from all the quality programs.
Correct.
Okay. And people were okay with that. People weren't tearing their hair out that I see more patients than anybody else. And
no, because usually in our model, in our compensation model, if they were seeing more patients, they were also getting paid more. Where that fell apart is obviously if they were seeing Medicaid patients, because it wasn't RVU based at that time. It was kind of cash based. But eventually we moving more towards RVU, which equalizes your Medicaid versus your commercial.
Yeah, I'm
Okay.
curious to find out. These dashboards are cool. What did you use? How did you pull them out of the systems? Because I presume they had different EHRs.
no, they're all one health system.
Oh, it was one health system.
This was one. Now, with the Accountable Care Organization, when we first set up the Medicaid Accountable Care Organization, we had FQHCs and independent practices and hospital-owned practices, and many of them weren't even on EMRs then. And this was 10 years ago. And so we actually were doing chart reviews. It was very labor intensive to start the process. And we did chart reviews and we gave them their data just in an Excel file every month. But it was still transparent. They could compare themselves to other practices. Once everybody was on the same EMR, it was much easier to extract the data, and it either came from the EMR or it came from the billing data. It depends on what you're doing.
And my experience with benchmarking physicians is that there's a lot of pushback, and people do not like that openness of Dr. Bravo is doing less well than Dr. Rogu on this metric. And they start getting really upset. And then they're in my office saying, that's not fair because it's like, well, we're measuring the same thing for everybody. So why don't you think about improving? No, that's wrong. That can't be, So how did you deal with that? Because that had to happen if there are 200 physicians.
Well, it was always, when I was involved, it was always a carrot. It never became a stick. In other words, we had no financial penalties for not checking the boxes or for not doing the antimicrobial stewardship or having a low HPV vaccination rate. It was always a carrot. So an argument was, that's all right. You're not losing any money on this. You're just not getting the bonus. And yes, your score is being compared to others people. But that's the way it is. That's the way medicine is moving. Whether it's good or bad, that's the way medicine is going. The other thing we did is we were transparent within a practice. So within a practice location, everybody could see each other's scores. Practice to practice, it was aggregated. So it was really your closest colleagues that would know how you personally are doing. Otherwise, you were only comparing to this site versus this other location site. And so it was not as confrontational as if we had completely made it transparent.
Well, I think people, doctors especially, are very competitive people, because I'm the president of a CIN, a clinically integrated network, and we have a dashboard and we have different EHRs, and we pull the data from the 827 files,
Yep.
and 835, mix it all up into a database, make pretty pictures. The insurance companies give you, from the value-based contract point of view, they give you nice reports, and they tell you, Herb, you did well on this and you did poorly on this. You could have made $50,000 for this metrics, but since you didn't complete it, you only made 20. But the organization, because the other group did better, as a whole, the big check came in. So we always had problems with the distributions because Herb would think, well, I got the most patients and I brought in that money. And then we would slap him on the wrist and say, Herb, next time you can get 50, do your job. And the competition started to set in. And then we figured out some practices were really, really good. And we asked them, what did you do to do that? We want to all aspire to be like you. And it created a little competition between the organizations.
Right. And then sometimes you can have the less performing practices visit the other practices and learn from them. There's all sorts of shared ways. But that's why I said ego is a main factor, I think, in driving these changes.
Correct.
You have to trust the data. Now, one of the challenges with any of this is whether you use the insurance company's data or your own data. And they're very different, because if you're using your own data, you're measuring the patients that are seen.
Right.
The insurance companies are measuring your panel.
Right.
And you may not even be seeing them. And it's a different mindset. And so we chose to use our own data, not the plan's data, because the doctors, they really go ballistic when you say, but I've never seen that patient. I've never talked to that patient. They've never been in our office and I'm being dinged for them. So we just made the decision to use our own data, but there are different people who do both sides.
Yeah, our organization does both. So we primarily uploaded to this database all the stuff that we did, and they pull it back from the insurance company. Then they mix it up to make sure that the insurance company actually reported on the service. And if they didn't, we have supplemental data. So we find out that the insurance didn't find us, and we push it to them, and we make sure that the doctor gets credit for it.
And that's very mature data mining, and it's the way it really should be.
Yeah.
That you can report back to the insurance company. Hopefully the insurance company will take your data. Sometimes they don't, and sometimes they only want it in certain file formats. So you have to be
they want it in a certain format. So we put it up there in a certain format.
Yeah.
So we're all just using this centralized database and basically just working off of it and filling it up and eventually give it into them.
It takes big infrastructure to do that. And so
and lots
I'm
of
thrilled
money.
you're doing that. Yeah. It
And
takes a
lots
lot of time to build that, and you have to have some pretty astute data scientists working it.
Yeah, we have a good company that does it. The first time when we did it, we used this regular data visualization company, which was pretty inexpensive. I worked with an engineer, and we pulled the data out of the different EHRs in an Excel format. You know, ECW had it right to left, and Office Practicum had it up and down. But at the end of the day, it was the same thing. So we just mapped them. We had some really nice pictures. It was really good. It was old data, so we could only pull the data that was in the past. So it wasn't actionable, but it was really cool to get contracts, right? And the replication was the complicated part. So I had to go back in 6 months and redo all these files and pull all these things out. Doctors usually participated at the beginning because it was a cool project. But the second time around, so leave me alone, leave me alone, leave me alone. And then the engineer moved to a different company. The new guy came in, I can do this. And he looked at it, he says, oh my God, I can't figure this stuff out. So we had to move a different company.
Design. But
So
to really get mature at this and robust, you do want it to be actionable data, because you want to be able to send to an office manager or a nurse and say, click here. Here's the 20 people that aren't meeting this metric yet.
Right.
Reach out to them before this deadline, and your score is going to go, way up.
Yeah.
And that's when it's actionable.
Yeah.
and is there a moral trap or quandary once you realize someone's, consistently below 50% on quality? Do we have a responsibility to either getting them to improve or leave the group?
I
Yeah,
think
it
that's up to
depends
the
on the
group.
organization. So
Yeah.
in our bylaws, we set it up where the idea is everybody does the right thing. And at the end of the day, there'll be some finances. And this is the future. And we have a cohesive organization that matters and people pay attention to it. And Herb, if you don't do your job, I'll tell you once, I'll slap your wrist the second time. I might kick you in the head the third time, but the fourth time you're out of the group. You could stay in the group, but you're out of the contracts. But that was set up in the bylaws.
The
How
other
about
thing, it's up to the culture. The other thing we did that helped quite a bit, I forgot to mention this when I was talking about physician change management, is as we were early in this, we made sure that what we did counted for MOC Part 4. And that helped a lot, because we would do CME, they get CME credit, they get their MOC Part 4 credit for quality improvement. It's much easier to get your MOC credit now, but it used to be difficult for doctors to get that.
Right.
So that helped a lot. Again, kill two birds with one stone. So make their life easier if you can, get them MOC credit, get them some financial, appeal to their ego, and you can begin to drive change. There's always going to be naysayers.
Yeah. You know,
And
without
so-
question, I'm wondering about, all this stuff is cool. It requires money. Who funds this? So you're funding something, you're asking for money to do something. Technology people will charge you a lot of money for something that you may get down in the future, some extra money. How do you fund these things? If you're from a hospital, I guess that's where it's from.
Yeah, it's becoming the price of doing business, right? It's just expected that you're going to do it. So you have to build that infrastructure. Hopefully, your Medicaid or your commercial plans are giving you funding to build that infrastructure. We were fortunate that we originally had a grant, but eventually it became Medicaid is giving you a care in Ohio, will give you a care coordination fee. As long as you're meeting certain targets, you will continue to get a PMPM. And so part of that PMPM is used for infrastructure, and part of it's used for your incentive plan. And then if you get shared savings down, it depends on your contract, whether it's upfront dollars and upside risk or downside risk. And eventually it's going to be the cost of business, because if you don't hit your targets, you can't prove it, your reimbursements will go down, or you're going to start to lose money.
Yeah.
Because CMS is pushing this more and more.
Oh, I know that.
And so you had some big wins. You were able to improve vaccination rates in influenza through the group by 10%. How did you guys get there?
By data mining. It was all data mining. We would find out who received, first of all, your patient base. You have to decide who's your patient base. So we would decide anybody you've seen in the last 2 years. Some people use 3 years, some use 2 years. That was the patient base. So then you said, well, who got a flu vaccine in the past? And that becomes your low-hanging fruit. Because they've gotten one in the past. Have they gotten one yet this year? And so you do outreach. And then the next is who's seen you for a well visit but didn't get a flu visit, because they're more engaged. So you want to go for the low-hanging fruit first and work with people who are engaged. And then your next level, so categorize who's an engaged patient and who's not. They've gotten a flu vaccine before, they're really engaged, they'll get it again. If they had a well visit, they're engaged at some level, so hopefully you can reach out to them and get them in for a flu vaccine. And the last are those people who haven't had a well visit or a flu vaccine. You can try some outreach, and you need to make the outreach automated. And so that it's just done on behalf of the doctors. The staff can't do it, they don't have time to be making all these phone calls. So it needs to be automated texts or emails or phone calls. And that's what we did. And then we also worked with the offices to offer flu vaccine, not just during their well visits, but any visit they came in during the fall. Really, we would start in September through December. Any visit they came in, have they had a flu shot? Our EMR at the time, and still, is not sophisticated enough to do an alert. Hopefully your EMR does alerts, but you'd have to go in and look to see whether they had a flu shot, which takes time, and then talk about it. All of this takes time, which is why the more you can automate it or have your staff doing it for you, the better. A lot of incentive plans, although I don't know if we did this with the flu shots, we did it later. If the doctors hit a certain quality measure and they got incentives, the staff got incentive bonuses too. If you incentivize staff, then they're going to make sure the doctors are doing their work too, remember.
Great. Great. And then you were able to decrease the cost of Medicaid, the population that you were taking care of, by 6%. How do you do that? Because they don't have the stick that the person with the high deductible plan has, that if they go to the ER for a cold, they get a $1,200 visit, they got to pay out of their pocket. So how do you do that? What did you do that made that possible?
That was a multi-year project, and the first thing it started with was us to identify drivers of Medicaid cost and where we thought there was opportunity. And as we looked at the drivers of Medicaid cost, we realized behavioral health was one place and children with medical complexity was another one. So we designed programs to address that. And then we implemented those programs. I'll explain it in a minute. Then we had to get a baseline data and our follow-up data, which was extremely difficult. We hired a third-party actuarial company, Mercer, to do that with Milliman. And we sent them all of our Medicaid data, and they tried to figure out pre and post-intervention cost of care. And that's how we came up with that 6%. It's very difficult, especially in children with medical complexity, because ideally you have controls. It's really hard to have controls when you're dealing with children with medical complexity because they're so different. So it was really pre and post population level data that we compared. The biggest interventions we did was for behavioral health, is we had crisis intervention social workers put into the emergency room. And it's because people were getting admitted for behavioral health crises because there was no resources to deal with these children. So the social workers would intervene and connect them with the community behavioral health agency the next day, schedule their appointment, get them. And so they didn't have to be admitted for social reasons. They could get community services the next day. That greatly decreased the hospitalization rate for behavioral health reasons, for mental health reasons. Now, if they're suicidal, if they need medication management, that's different. Right. But a lot of the times it was just crisis management, but they had to be put in the hospital. And this was, again, 9 years ago. And for children with medical complexity, we built an inpatient team that was the same as an outpatient team managing children with medical complexity. When children with medical complexity get admitted to the hospital and you have a hospitalist team or an inpatient team managing them, part of the problem is they don't know the patients. They don't know their baseline. So they don't know when to discharge them, or they don't have appropriate follow-up. So once we had a consultative team on the inpatient that was the same as the outpatient team, they knew the patients better. They had trust with the families or the caregivers. They weren't families or foster care families, and they could coordinate discharge and get the kids out of the hospital much quicker. So it reduced the length of stay for those children. And these are all outliers. They weren't just paid on DRG anyhow, because their length of stay were longer and they were high-cost kids. So those were the two main cost-saving interventions we did. And it's because we were focusing on getting kids out of the hospital or preventing them from even getting in the hospital.
And so it sounds like we're kind of going back to back to the past by having your outpatient team be your inpatient team in very complicated patients, as opposed to, like I round on my own patients. I know them well. I know who will come back to follow up, who won't, so I can send them home a little earlier.
And that also means that the pediatricians had to work. We had a medical complexity team. And so your general pediatricians had to have confidence and want to refer their kids to this team, which had a social worker, a dietitian, somebody with neurodevelopmental disability board certified, had a nurse. So the pediatricians needed to kind of co-manage them with this team. Otherwise, it would fall apart. And that took a journey too in itself. A lot of pediatricians wanted to manage these children on their own, but when you co-manage it, it would work much better because the pediatricians had to realize they're getting a whole team.
Right.
And often the pediatricians don't have a social worker, a nurse, a dietitian in their offices to help manage children with medical complexity. These are the top 1% spend of kids.
Yeah.
Right.
And then since I'm a private pediatrician, I'll ask you once again, how do you fund these things?
Well, this was funded by a grant.
Of course.
And it was great to prove the program. And we have failed to get the Medicaid plans, unfortunately, to continue that funding because these kids are, in Ohio, we have Medicaid managed care. And so each plan is only managing so many of these kids.
Right.
And it's still nothing compared to their dual eligibles and how expensive they are. So getting the attention. And many of them have dual insurance. They have commercial primary and Medicaid secondary because they're so sick. So it's a systemic failure. Many programs around the country for children with medical complexity have proven their benefit. They keep kids out of the hospital. They decrease healthcare costs. They decrease medication costs. But nobody's paying for the programs. It's the right thing to do, and you're absolutely right. So for you, again, it'd have to be the CIN paying for it. If the CIN can reap the benefit on the back end. Now, if you're taking capitated risk, and there are some programs doing that, not many, but there are some pediatric programs around the country taking capitated risk, then it's going to pay for itself.
Yeah.
Where do you find these social workers? The access to mental health is extremely difficult.
Social workers are a lot easier to find than psychologists and psychiatrists, believe it or not. We never had problem finding social workers. It's interesting. It's a great question. We never had problems finding social workers. Nurses, yes. Psychologists, psychiatrists, yes. Social workers, they were there. We didn't have trouble.
Oh. And what do you think were, you did this for a whole decade, right? Where were the biggest lessons of your journey? And why did you eventually decide that you wanted to do something different?
I think the greatest lessons and the most enjoyment I had was what we've already talked about, getting physicians to change the way they're delivering care, hopefully raising the quality. Some of it was just checking boxes. I'll be the first to admit it because we had to because of the Medicaid plans. But some of it, I really felt we're improving care. We did a whole lot of work around behavioral health and toolkits and monitoring medications. I was very proud of that and had a lot of fun building the dashboards and driving change there. That was a lot of fun. It became harder and harder for me to continue to drive that change. Health systems have so many competing priorities right now. Children aren't always at the top. Medicare is when you're in a health system. And it became much harder to advocate for the doctors. As I would tell people, I never minded doctors complaining to me. That was my job, right? And when a doctor complains to you, it can take one of three avenues. they're either wrong, and you just tell them, I don't agree with you, you're wrong. Or you say, you're absolutely right, and we're going to fix this for you. And then there's the third one, which is very draining. You're absolutely right, but there's nothing we can do about it. And that one becomes very difficult to continue to manage. And eventually it can gnaw at you. And I just felt that there wasn't an opportunity for me to continue to drive change in the way that I had previously. And that the way that driving change and advocating for the doctors helped offset all the failures that I was faced with. And eventually there were more failures and less successes, and which is very difficult. And I'm not blaming the health system at all, because it's a hard industry. The system is becoming more broken, not fixed. So it's just time for a change for me.
And through your consulting firm now, what is it that you're aiming to achieve? Are you trying to help CINs like Georgia's CIN? What do you see yourself doing through this consulting firm?
I've had a wonderful career. I'm very fortunate in that, I've been in private practice. I've been part of a children's hospital leadership team. I've been part of a health system. I've been part of population health, helping to run ACOs, CINs. And so I bring a lot of different perspectives, and the consulting I'm doing is across that spectrum. It's population health, yes. It's community engagement in population health, so a little more public health. And what I'm enjoying the most in the consulting work I'm doing is actually startups. There's a lot of startups in the adult world, right? You hear about them every day. In the pediatric world, it's a relatively small community. There are startups, and when I say startups, it's whether it's technology, whether it's programmatic, whichever, school-based care, telemedicine, all sorts of startups. A lot of them happen within health systems, and they have their own network and they work together. There are very few pediatric startups in the for-profit venture capital world. And that's where I'm having the most fun, is I really feel that I have something I can bring to them with my varied experience, and to give them guidance on how to navigate patients, pediatricians, health system, population health, all of that. That's what I'm enjoying the most.
Wow. Any thought into trying to get grants to get a bigger CIN, where, like the data collection?
I'm not involved with that myself. I know there's some other pediatric consultants that can be hired to help write those grants to try to get them. There is money out there. There's a lot of money out there for early childhood. There's money out there for telemedicine and virtual care to try to prove that'll change the trajectory of kids. I'm not directly involved in that. I have helped some of the startups try to get grants for startups, and I've helped consult on that, but I myself am not doing that.
Because it would seem like the more data you have, the more data points, the more you can learn, and there's some efficiency in the resources you're spending, right? If you got 500 or 1,000 pediatricians all chipping in for the data mining organization, it's a small cost per pediatrician. If you got 2 of them splitting it up, it's a huge cost.
Right.
And so, I think that's where pediatricians, we haven't worked with each other, because we need to have more data that's ours, so we can even assume to compete with the data that somebody like Optum has. You can have 200 pediatricians. That means nothing. They have 60,000 physicians. Right. So
I think we can all do a better job trying to link up startups, especially population health that can impact, and the pediatric physician networks. I know there's companies trying to do that, but I think we all need to do a better job of that.
Yeah. No, it's the funding of the technology that's the hardest part. I mean, the network of physicians, it's very easy. Lots
It
of
is, but getting them engaged, which
Getting them
requires funding.
Getting them engaged is relatively pretty easy. They're good for it, but there's always the "what's in it for me" statement. And if you get a physician enrolled, then you got to go to the technology company, and these guys, they want a good amount of money. And you got to find funding. We're a private organization. We're a clinically integrated network with a sole tax ID number just for the wraparound contracts and things, just basically so we could connect and work on things and so forth. We're funding the dashboard through membership through the practices, which is, I guess, enough. We have a couple of contracts. Hopefully they'll pay something in the future, but you have to expand that. Dashboards, you have to expand it. You have to have a good idea. You have to, work it. I'm working with this company that's looking at us as the pilot, proof of concept that it can be done. But how, we're paying something, probably not paying enough, I think, but I would love to get a hold of somebody to help me with some kind of a grant where we can, funnel some money into the technology to make it better, and getting the doctors on board is the easy part.
Well, the challenge, as you know, for pediatricians,
Yeah.
it's the cost of care for kids. So if you decrease the cost of care by 10% in the Medicare population, you're saving $900. The average Medicare cost is $9,000 per member per year, right? In kids, it's commercially insured kids, it's $3,000. Medicaid, about $5,000. So saving 10% is not going to pay for all the interventions in children as it would for an adult. And this is the challenge. We're too short-sighted.
Yeah.
Because we'll save money 10, 15, 20 years from now if we can make a difference in a kid's life. But you're not going to save the money right now.
Yeah. Right. Well, all I can say is I have the network of doctors. I have the platform to get other doctors on board. We have the technology. We have the infrastructure. And if there's anybody out there in the world that wants to help us with the grant to make it better, I'm all ears.
Well, I think it's more than just a grant. You need people like Drew.
Yeah.
Because ideas don't just come from the computer.
Yeah.
And you need to grow bigger and bigger so that the cost per physician keeps going down and down.
Right.
And plus, what we've just talked about. Once I figure out how to do X really well, I can teach the other 500 pediatricians in the network.
Yeah.
This is how we got to this point, and they can all just copy it. And we're not all reinventing the wheel and banging our heads against the same wall in our silos over and over again. The numbers, 500, 1,000 pediatricians, otherwise you're too small.
Yeah. Well,
one of my favorite clients, or I should say most interesting clients, maybe I should say, is a large data analytics company. And I approached them because there is no data analytics company, to my knowledge, focusing on pediatrics. Many have tried over the years. The market is small. The market is much smaller than in the adults. Medicaid is a state program. It's not a national program like Medicare. But I did get this one company, or it was a mutual agreement, and we're creating a pediatric center of excellence. And I work with them every week to try to get their products and thought processes to think about kids. And it's all data analytics. But the workflows are different. The metrics have to be different. There are unique problems to kids. Linking kids together as families. You don't deal with families in the Medicare world as much.
I know.
And I'm very excited about this, but it's a constant battle, just like in the health system, because they want to focus so much on the larger dollars available to them in the Medicare world.
Right. Well, I'm fortunate to be working with Hertz Consulting. Henry Dennis is the guy, and he believes in pediatrics and the Medicaid world, and he's helping to get this off the ground.
Excellent.
He's depending on me to get the doctors to him. And, you know, most of the people like me most of the time, and I tend to be able to move people. So we'll see what happens in the future.
No, it's exciting. Good luck. Good luck.
Well, thank you so much for sharing the time this morning. It's
No,
a
been my
fascinating,
pleasure. Enjoyable.
fascinating journey that you've
Yeah.
had.
Yeah.
I've had a
Um,
blast. It's been a
Well,
lot
this
of
is
fun.
the future. This is definitely the future of medicine.
and what we haven't solved is how do we get that message out that children are important. Every dollar spent in a child has an ROI of maybe $100 if you're looking 30 years out. For society. We need to stop this quarter to quarter.
It's hard. It's
Measurement.
hard. Kids don't vote, and they're not as expensive as the adults. But part of the reason we're in the mess we're in today is because we didn't take care of the kids 20 years ago,
That's right.
30 years
That's
ago.
right. That's
Yeah.
right.
Yeah.
All right. Well, thank you so much, and wish you the best of luck. And hopefully, we'll see each other soon again.
Thank you. Thank you
All
very
right.
much.
Bye bye.